My name is Dr. Ameerah Davids. I am currently a registrar in the Division of Chemical Pathology at the University of Stellenbosch in South Africa. I'd really like to thank the organizers for providing me the opportunity to present this interesting case of a patient with a delayed diagnosis of hypogonadotropic hypogonadism in our resource-limited setting. Okay. So the outline for my talk, I'll start this case presentation with an introduction to puberty, followed by the case presentation and the role of the laboratory in delineating the underlying pathology. I'll then follow with a discussion regarding the workup of delayed puberty, and then end off with the conclusion and some take-home messages. So starting off with our introduction, this case presentation revolves around a patient presenting with a complaint of delayed puberty. So I'll start off this presentation with a brief overview of this clinical presentation. So puberty is a physiological process which is defined by the development of secondary sexual characteristics and the attainment of reproductive function. For puberty to occur, there's an intricate interaction between the hypothalamic pituitary axis and the pulsatile secretion of the gonadotropin-releasing hormone, where the interaction between these mechanisms is under genetic, endocrine regulation, as well as environmental factors. It's really important to note that puberty is an important milestone in many cultures and impacts both physical and psychosocial well-being. So the clinical assessment of delayed puberty is traditionally confirmed at the age of 13 years in girls and 14 years in boys. However, the timing of puberty is very population specific, and it has also been suggested that puberty is occurring at a much earlier onset. An alternative proposed definition for the assessment of delayed puberty has been defined as the absence of testicular enlargement in boys and the absence of breast development in girls, which is 2 to 2.5 standard deviations from the population mean. In South Africa, we unfortunately don't have any published guidelines on the age cutoffs to make the diagnosis of delayed puberty. However, at our institution, our pediatric division utilizes the cutoff of 14 years in males. There has been a study performed by Jones et al. In South Africa who described the median age of puberty in our setting to range between 9.8 and 10.5 years for boys and girls across different races, which is in keeping with the suggestion that puberty is occurring at an earlier age. So I'll now start off with our case presentation for this patient. So our history starts off with a 19-year-old male who presented with a failure to develop secondary sexual characteristics. On background, it was noted that this patient did seek medical attention already at the age of 16 years old, however, was inappropriately reassured by the medical practitioner that these findings were normal and no further laboratory investigations were performed. The family thus represented the private healthcare setting where they were then referred to state healthcare with the clinical findings of short stature, a high-pitched voice, and a lack of secondary sexual characteristics. On inquiry from the patient, he confirmed that he had no axillary hair growth, no voice changes, no history of coarsening of his facial features, no development on acne, and he had the concern of minimal growth of his genitalia. He also reported no anosmia, where anosmia is the inability to smell. On further inquiry of his background history, no chronic illnesses were elicited from the patient or his mother. No underlying psychosocial stresses other than this concern of the delayed puberty were found. He reported no eating disorders, no exogenous substance use. He also notably had an unremarkable perinatal history where he had a normal birth weight of 2.5 kilograms and no postpartum complications. He also achieved normal milestones for his age. In terms of his family history, he did have one older brother who achieved normal puberty at the age of 14 years. Unfortunately, his father demised, and there's an unknown pubertal history on his side. In terms of the clinical examination for our patient, he noted it was noted that he had a normal body habitus and no clinical dysmorphism. He did have a low BMI of 17.9 kilogram per meter squared, which is considered underweight, where the normal range is between 18.5 and 24.9 kilogram per meter square, with a weight of 51.1 kilograms. He was noted to have no gynecomastia, no axillary or pubic growth was confirmed, and on genitourinary examination, his phallus measured 4 centimeters and his testes were 2 centimeters bilaterally, where this correlates to a Tanner stage 1 criteria. And if we look on the table on the side, of the different Tanner stages that are used, we can see that stage 1 correlates to a prepubertal level, where his testes is below the 2.5 centimeter in the longest dimension. So he is considered to be prepubertal with pubertal delay. And then just of note, he had no other significant findings on clinical examination. So just to summarize our case thus far, we have a 19-year-old male presenting with pubertal failure. The clinical assessment at this point was that of clinical hypogonadism, where at this stage it was unclear if it was hypergonadotropic or hypogonadotropic. And the plan was to perform baseline laboratory investigations to exclude any underlying systemic illnesses, to include in that an endocrine assessment, including luteinizing hormone, follicle stimulating hormone, testosterone, prolactin, and cortisol, as well as imaging to review his bone age, and to consider performing an MRI, depending on what his laboratory investigations were, to assess if there might be a hypothalamic or pituitary lesion. So going through his diagnostic results, I just summarized his results on the side, as he had normal renal function, normal thyroid function, liver functions were also normal full blood count, and was noted to be HIV negative. And again, just to exclude any underlying systemic illnesses. In terms of a summary of his endocrine laboratory investigations, he had a normal cortisol level as well as a normal prolactin, where this it does not suggestive of a pituitary lesion. We can note that he had low gonadotropins, where we can see that his FSH and LH were both significantly decreased with a low testosterone, which is then in keeping with a hypogonadotropic hypogonadism in this patient. Hand X-ray was performed to assess his bone age, where he did have a delayed bone age of 17 years, which is 2 years below what it should be, which is to be expected with a low testosterone concentration, as testosterone is needed for bone density mineralization. It was decided to perform a MRI in this patient, a cranial MRI, which was normal and confirmed that there was no underlying hypothalamic pituitary lesions. So the differential in this patient, given the laboratory and imaging results, was between constitutional delay of growth and puberty, also known as CDPG, versus idiopathic hypogonadotropic hypogonadism, also known as IHH, where CDPG represents the extreme end of the timing of puberty. So your patients who are presenting at past the 2.5 standard deviations for that population. And it is the commonest cause of pubertal delay, and it's very much a diagnosis of exclusion. The difference with IHH is these patients never obtain puberty. So regardless of how much they age, they will never reach puberty, as opposed to patients with CDPG. And this diagnosis is made once a patient reaches the age of 18 years old. And again, is also a diagnosis of exclusion, but certain guidelines do recommend that it does require the exclusion of hypothalamic pituitary abnormalities. What's important to note is that IHH can also occur with patients with normal or abnormal olfaction. So that's why it's important with patients who present with delayed puberty to take note if they do have abnormalities in their smell, as patients with this abnormality are defined as having Kalman syndrome, where there's hypoplasia or sometimes complete aplasia of the olfactory bulbs, leading to this anosmia in these patients. So in our case, the diagnosis of idiopathic hypogonadotropic hypogonadism was made essentially based on this patient's age at the time the diagnosis was made, when he was 19 years old. And clinically, he had no other features suggestive of any other underlying systemic illness, no other genetic abnormalities, and his laboratory findings were in keeping with hypogonadotropic hypogonadism. So this is the diagnosis made in this patient. In terms of the outcome, he was initiated on exogenous testosterone replacement, where this table just summarized what his initial results were. His testosterone levels at 1 month of treatment and then at his 4 month follow-up, where we can see that there was a slight increase in the testosterone concentration. Of note, at his 4 month follow-up clinic appointment, he positively reported that he had improved muscle strength. His weight had already improved by 3 kilograms, and also some axillary and pubic hair growth were noted. The plan at this stage was to continue his serum testosterone and to continue laboratory monitoring. And the decision was made at this stage that no further genetic testing would be performed, as it wouldn't alter any of the management in this patient. Unfortunately, this patient has been lost to follow-up. He lives 250 kilometers away from the closest tertiary center, and also the family reported quite very much difficulties with routine follow-up, which we sometimes do see in our patients in the public healthcare setting. I've also checked our national laboratory system, and he has no record of follow-up serum testosterone levels being performed, which gives the impression that he's not being seen at his local healthcare facility either for further management. So just some diagnostic challenges in this case. Firstly, is to note the inappropriate delay in laboratory investigation in this patient at the initial presentation when he was 16 years of age. So it's unclear whether there was a lack of awareness by the initial clinician, which seemed to be a private general practitioner, of the further laboratory investigations that are needed in patients who present with delayed puberty. Also, just to note that the differential diagnosis of hypogonadism really relies on laboratory findings to distinguish between the two types, which then gives us a differential to the different causes. Also, just in our setting, we have very much limited availability of genetic testing, where it doesn't typically impact the management of patients, and we don't routinely perform them for certain disease processes due to the cost implication. However, this also does result in a lack of local data of genetic dysmorphisms we might have in our setting. So just going through a discussion of delayed puberty. This is the hypothalamic pituitary gonadal axis, where we can see there is a pathway for both males and females. Just for the sake of time, I'm not going to go through the entire pathway, just so that this diagram really highlights the interplay between genetics, endocrine, and environment, between this very fragile pathway that is needed for puberty to occur. This diagnostic approach was published by Lehman et al. And shows a nice diagnostic algorithm which can be used in a patient who presents as a phenotypical male with delayed puberty, where we can see the initial testing includes assessment of your TSH, T4, and prolactin, which was as performed in our patient, where the testosterone, FSH, and LH are also performed. And once we've confirmed that the patient is hypogonadal, the FSH and LH is really what guides us to say whether we're going the hypogonadotropic or hypogonadotropic route, and that gives you quite a long list of possible differential diagnosis. Just to note that the hypothalamic causes does exclude some other underlying illnesses such as eating disorders, stress, exercise, not included on this diagram, or other chronic illnesses, which just highlights the fact that in these patients, you need a thorough clinical history examination and laboratory investigations to give you a full clinical picture of what the underlying diagnosis might be. Again, in this algorithm, they do suggest performing a karyotype in patients diagnosed with IHH. However, in our case, in this index case, it was decided not to, just based on all the clinical and laboratory findings. So the strengths of this case just highlights the core role of the laboratory and the investigations performed in the diagnosis in this patient, as well as the role the laboratory plays in also monitoring response to treatment in these patients. Limitations, unfortunately, in this case is that initial delay in diagnosis, where the lab can play a role in clinician education of patients presenting with this clinical syndrome. Secondly, unfortunately, the patient was lost to follow-up, so we are unable to review the clinical and biochemical outcome. And then lastly, as mentioned, the limited access we have to genetic testing in our setting in the public sector. Just from the patient and the clinical perspective, from the clinician point of view, is that the clinical findings alone can't really delineate the underlying pathology in patients presenting with delayed puberty, and that delineation relies solely on laboratory findings. So we play a crucial role in patients presenting with delayed puberty, regardless of the age. And then laboratory findings really guide the diagnostic pathway as mentioned, and that is ultimately what decides the treatment modality of these patients. And then lastly, we're also extremely involved in the monitoring of serum testosterone after the treatment has been initiated, where both your clinical and biochemistry can be used to monitor response to treatment. And then from the patient perspective, this diagnosis was very much made with non-invasive diagnostic modalities, which from a patient point of view is very much appreciated. And then secondly is that the laboratory investigations in this case led to a diagnosis, allowing the initiation of treatment, which did show a good clinical response initially while the patient was on treatment. So just some take-home messages is that the diagnosis of delayed puberty can have physical and psychosocial implications. Thus, adequate clinical investigation and management are required, and the diagnosis and management of delayed puberty are reliant on laboratory investigations, and acquired conditions need to be excluded as these are often reversible. These are just some of my references. Thank you.